Welcome everyone to our webinar. We are thrilled to have you with us. Thank you for being here. So let's get started. We're going to talk today about everything you always wanted to know about Ehlers-Danlos Syndrome, EDS, and hypermobile spectrum disorder, HSD. This is the second edition of this webinar. The first one was held on May 29th, 2025, and it's available in Reconnect's YouTube channel. We have an exciting session planned, and the agenda for today is as follows. We will begin with an introduction of the speaker and the moderators. Before starting, we will provide you with some helpful tips before we dive in. We will then get straight into answering the questions regarding everything you always wanted to know about EDS and HSD. Afterwards, we will open the floor to questions from the audience. We will wrap up with a final summary, and finally, we will say our goodbyes and conclude the session. Next slide, please. Yes, so here's an introduction of the expert and the speaker of today. The expert speaker of today is Dr. Marco Castori. He is the head of division of the medical genetics at Fondazione IRCCS-Casa Sollievo della Sofferenza in Italy. Dr. Castori is a clinical and molecular geneticist coordinating a group of clinicians and nurses in the diagnosis and care of individuals with selected genetic and rare diseases, also including hereditary connective tissue disorders. He also supervises the activities of a diagnostic and research lab focused on the same conditions. He's also the coordinator of the Institutional Rare Disease Program. Next slide, please. Charissa and myself will be the moderators for this session. Let me introduce myself briefly. I am the Vice President of ANSET, which is the Spanish patient organization for Ehlers-Danlos Syndrome and hypermobility spectrum disorders. I also serve as an ePAG advocate for the ERN Reconnect and for the EDS and HSD disease group, as well for the ERN Vascairn and the vascular Ehlers-Danlos syndrome disease group.
Good afternoon, everyone. I'm Charissa Frank. I'm the president of the Bindweefsel.be patient organization in Belgium. I'm also an ePAG advocate here in Reconnect and for the EDS HSD disease group. I'm also the secretary for the Flemish network for rare disease for connective tissue and musculoskeletal. I'm a patient expert for the EMA and the EDS Society International Consortium Workgroup member. Before we start, I'm going to explain to you some of the scope of the webinar and the housekeeping rules. The scope of the webinars, we're going to try today to solve the patients and the carers' questions about the Ehlers-Danlos Syndromes for EDS and hypermobility spectrum disorders of HSD. The questions were previously collected through a survey from the ERN Reconnect EDS disease group. Questions will be answered live by our expert, Professor Marco Castori. In addition, the chat will be open for your questions. You can ask these just in the chat, but also in the Q&A. Our housekeeping rules for today. You can write your comments and questions on the chat. Language of the webinar is in English. Translated live captions into your mother language can be activated. This webinar will be recorded and published in the ERN Reconnect website and YouTube channel. Disclaimer: this webinar is meant for informative purposes and cannot be taken as a medical consultation. How do you activate the translated captions? In your Zoom bar, click Show Captions. Open the caption settings. Activate translation. Speaking language, English. Caption language, select your native language. So, Everything you always wanted to know about EDS and HSD, getting your questions answered. Let's start. The categories: comorbidities and symptoms, lifestyle, where we will answer questions about nutrition and health conditions, diagnosis in pediatrics, and research. Eva?
So let's start with the first category and the first question. Dr. Castori, what is the relationship between EDS and the immune system? I am polyallergic and post-COVID, I constantly get sick with major respiratory flu.
Thank you, Eva. Good afternoon. Ehlers-Danlos syndromes, by definition, are pleiotropic conditions caused by mutations in single genes with long-lasting effects in the functions and/or morphology of different organs and systems. In this view, it is reasonable to hypothesize that Ehlers-Danlos syndromes might present with selected dysfunctions of the immune system. Nevertheless, periodontal Ehlers-Danlos syndrome is the unique one in which the immune system appears directly involved, both at the molecular and clinical levels. This is an ultra-rare monogenic form of EDS, caused by heterozygous variants affecting two genes, C1s and C1r, encoding for complement subunits. People with this form of EDS may occasionally present recurrent infections and autoimmune disorders. Moreover, a handful of publications in the last 2 years highlighted an apparently high rate of infections and mast cell activation syndrome in people with hypermobile EDS and hypermobility spectrum disorders. This finding does not have, at the moment, an explanation on a causal perspective and does not offer any suggestion to how to use such an epidemiological evidence in clinical practice. Little evidence is still available in support to a statistical significance for the apparently high rate of infections in people with hypermobile EDS or HSD compared to the general population matched by ethnicity, sex, and age. In summary, while an ultra-rare monogenic form of EDS is caused by mutations in genes directly involved in the immune response, and there are some scattered data suggesting an apparently increase in the rate of symptoms and comorbidities linked to a dysregulated immune system in HSD and hypermobility spectrum disorders, such observations still remain within the boundaries of clinical research. Clinical practice, a wise approach is to not simplistically explain comorbid infections and mast cell disease with an underlying hypermobile EDS or hypermobility spectrum disorder in order to avoid to be excluded from more effective treatments or from the recognition of more severe diseases. This is my opinion. Next question, please.
Thank you very much.
You're welcome.
So another question, this is quite popular amongst the patient community. Is it true that EDS is often linked to another condition such as ADHD, ODD, autism spectrum disorder?
Thank you for the question, because this is one of my points of interest. Anyway, attention deficit and hyperactivity disorder, obsessive compulsive disorder, and autism spectrum disorders are not currently included among the major and minor criteria of any rare variants of EDS. And there is not any convincing publication yet supporting that these neurodevelopmental disorders are more common in people with a causative variant, also a mutation in one of the genes associated with the monogenic forms of EDS. On the other side, however, there are observational studies documenting an apparently increased rate of attention deficit hyperactivity disorder, autism, and less significantly obsessive compulsive disorders in people with a prior diagnosis of hypermobile EDS and HSD. More data seem available for the presumed association between autism and the spectrum. A recent review by the Professor Baeza Velasco's research group highlights a presumed high rate of autism among people with hypermobile EDS and HSD, and vice versa. The association seems stronger if we consider joint hypermobility alone, so independently by the presence of or not of symptoms or by the criteria for hypermobile EDS. Again, evidence documenting statistical significance in comparison to the general population is not always available. Not all studies present a comparison with the general population. An unbiased approach to the literature seems to support the hypothesis that generalized joint hypermobility is a predisposing or associating factor to neurodiversity, and that their co-occurrence in affected but also unaffected cohorts, so people with asymptomatic generalized joint hypermobility, might stand for underlying covariability of continuous variables under the pressure of human evolution. In the meanwhile, such an evidence is still of little help in clinics. Thank you.
Thank you very much.
You're welcome.
Could you go back, Charissa, to the previous slide?
Yes.
There was still a question.
Charissa, please, the previous slide. Because we lost the third
last
question. The question, perhaps, hernias.
Yes, indeed, related to
Yes, abdominal wall hernias are a common finding in many monogenic variants of EDS and represent one of the 12 items for the criterion 2A of hypermobile EDS. Hypermobility spectrum disorders currently do not have any diagnostic criterion. The term of hypermobility spectrum disorders is used to describe, as we know, a non-causal association between musculoskeletal complaints and spatially related joint hypermobility. HSD were first introduced in 2017 to assign a diagnosis to people that present symptomatic joint hypermobility but do not respect the clinical criteria for hypermobile EDS. Nevertheless, HSD are in phenotypic continuity with hypermobile EDS. Therefore, it is reasonable to find scattered features of hypermobile EDS also in people with HSD. In conclusion, while we don't have any precise estimate of the frequency of abdominal wall hernias in hypermobile Ehlers-Danlos syndrome and HSD, we could accept to find hernias frequently among people with HSD. It is really common in our clinic. As a final remark, please remember that hiatal hernia is not a subtype of abdominal wall hernias because the criterion is strictly related to anterior abdominal wall hernias. Thank you.
Thanks for the clarification. Thank you. So we will continue with more questions about comorbidities and symptoms. Another question. I've suffered from constipation and gastrointestinal bout since birth, and nobody can find out what it is. Medication doesn't help, and I always have air in my stomach. What do you think, Dr.
If the patient is affected by hypermobile EDS or HSDs, please should consider that her symptoms are very common among people with this diagnosis. The reason as to why individuals with hypermobile EDS and HSD frequently present functional gastrointestinal symptoms is not completely understood. There are many papers documenting an increased rate of functional gastrointestinal disorders in people with hypermobile EDS and HSD, and this might suggest that in this patient's category, the gut is intrinsically dysfunctional. In parallel, there are publications supporting a strong tendency to concur for Ehlers-Danlos and HSD with small fiber neuropathy. And small fiber neuropathy is an emerging nosological entity characterized by a reduction of non-myelinated nerve terminations in the context of dermal extracellular matrix. People with this condition often present pain, tingling, burning sensations, and a plethora of visceral symptoms caused by cardiovascular, gastrointestinal, and blunder functional neurological dysfunctions. Accordingly, people with small fiber neuropathy often present a complex gastrointestinal symptomatology caused by gut dysmotility, and it is reasonable to think that people with hypermobile EDS and HSD who report gastrointestinal symptoms also present an underlying gut dysmotility, especially if they also received previously received a concurrent diagnosis of small fiber neuropathy. Personally, in people with multiple or severe gastrointestinal symptoms, always recommend supplementary investigations for an underlying small fiber neuropathy. And often I found the co-diagnosis. Next one, please.
Thank you very much for this clarification. The next question, is there a predisposition to urinary tract infections in general with
This point is much less clear than the previous one. Anyway, in general, in the occipital horn disease, that is an hereditary connective tissue disorder that shares many features with Ehlers-Danlos syndromes, and occasionally in other selected variants of monogenic EDS, we can find bladder diverticula, which are a non-anatomical predisposition to urinary tract infections. However, such a phenomenon is presumably very rare or exceptional. In people with pelvic prolapses and bladder dysfunctions, with or without the evidence of small fiber neuropathy, it is possible to observe occasional or recurrent urinary tract infections. In summary, urinary tract infections are not primary features at the moment of EDS. Nevertheless, selected complications and comorbidities might represent predisposing factors to urinary tract infections. Their treatment at the moment should be guided not just by the pre-existing diagnosis of EDS, but rather by the concurring complications and comorbidities. Thank you.
Thank you very much. We will move on to the next question. Also quite popular. What about HEDS and mitochondrial dysfunction?
Yes, it is popular and fascinating point. Anyway, the possible connections between hypermobile EDS or more in general, EDS and mitochondrial disease or dysfunction is a promising field of research given the related therapeutic perspectives. However, at the moment, the evidence is scanty. Two recent papers, which apply a multi-omic approach, highlight the possibility that mitochondrial abnormalities might contribute to the pathogenesis of hypermobile and vascular EDS. Chronic morning and post-exertional fatigue are common features in people with primary and secondary mitochondrial disease, as well as with hypermobile EDS and HSD. Therefore, it is reasonable to hypothesize a secondary mitochondrial disease, hypermobile EDS, but further studies are needed. I cannot say more on this point. Thank you.
Thank you very much. We still have some more questions regarding this category. It's been by far the most asked one. 1 second. We will get there. No worries. Yes. Could you go back, Charissa, to the previous one? Thank you very much. Now it's the next one. But again, we will get there. Thank you very much. I have problems with concentration, memory, and I get brain blackouts similar to absences. Is it possible that EDS affects the brain?
Concentration and memory difficulties are not primary features of EDS and HSD to date. However, chronic pain, fatigue, POTS, all common in people with hypermobile EDS and HSD, often associated with concentration and memory troubles. In conclusion, while EDS do not primarily affect the brain, some complications and comorbidities might facilitate the development of concentration and memory difficulties in these patients. So the response is quite similar to the response that I gave for urinary infections and gastrointestinal issues. Thank you.
Thank you very much. So moving on to the next question. Why are there clear cases of hyperlaxity that include visceraptosis, gastraptosis, and others that have these comorbidities but no hyperlaxity?
This is a question for a geneticist. This question allows a response only. This question allows a response only in the context of hypermobile EDS and HSD. In contrast to the rare EDS variants that are all caused by a single deleterious mutation in a single gene with pleiotropic effects, robust data document that hypermobile EDS and HSD are not monogenic disorders. As both aggregate in families and the two diagnoses frequently segregate as a single trait in a given pedigree, in other words, in the same pedigree, I can find people with symptomatic joint hypermobility, but not the criteria for hypermobile EDS, and other people with all the criteria for hypermobile EDS. So I can assume that these two diagnoses segregate together as a single familial trait. So it is reasonable to consider hypermobile EDS and hypermobility spectrum disorders as a single biological phenomenon associated with a complex or polygenic etiology. In this scenario, the absence of any obligate trait is the rule rather than exception. So it is normal that you can observe, that you cannot observe any single feature in all affected individuals. Accordingly, the existence of people with two or more comorbidities but lacking generalized joint hypermobility is not only possible, but is also expected, so it is normal. Hence, the real question is, can we use the term hypermobile EDS or HSD for people with comorbidities without musculoskeletal involvement? In my opinion, we cannot, or at least we cannot yet, with the current nosology.
Thank you very much. We are taking the last three questions on comorbidities and symptoms. Next slide, please. Yes. Craniocervical instability almost always concurs with EDS. Is all joint instability genetically related to connective tissue disease?
I am sorry, but the sentence craniocervical instability almost always concur with EDS is not right. Craniocervical instability is a symptomatic condition by which the joints beneath the skull base are unstable, with consequences in terms of local regional musculoskeletal pain, compression of peripheral nerves, and adjacent central nervous system structures. Instability of the craniocervical region may be caused by ligamentous laxity, but also by other mechanisms such as traumas, skeletal dysplasias, and metabolic disorders, for example. In case of craniocervical instability due to ligamentous laxity, but without accompanying primary bone and muscular diseases, the finding may affect a single body segment, such as the ligaments of the skull base, or be generalized, as it happens in generalized joint hypermobility. Finally, generalized joint hypermobility sometimes occurs in the context of monogenic syndromes, such as the rare variants of EDS. So it's not so common to observe craniocervical instability in combination with EDS. When you observe this combination, it is reasonable the consequence of laxity of the ligaments of the skull base, but you can observe craniocervical instability also outside the boundaries of EDS, because people might have an unstable craniocervical region independently from the underlying laxity of the ligaments.
Thank you very much, Marco.
Okay.
The next question is regarding HEDS and neuroimmune involvement.
We say something in two previous response anyway. There is not any direct relationship between hypermobile EDS or HSD and dysregulation of the neuroimmune system. Recent literature highlights a higher rate of small fiber neuropathy and symptoms compatible with mast cell activation syndrome in people with a clinical diagnosis of hypermobile EDS or HSD. The coexistence of hypermobile EDS or HSD, small fiber neuropathy, and mast cell dysfunctions is at the moment without a formal biological or mechanistic explanation. These three conditions seem to concur together with a higher rate than expected by chance, but this is likely the consequence of specific biological or pathophysiological mechanisms that wait to be elucidated. Before scientific discoveries will clarify this issue, my recommendation is to treat these conditions separately if they concur in the same individual, because we don't have any strong evidence that treatment might be influenced by the concurring diagnosis at the moment. Done. Next question.
Thank you very much, Marco. So
You're
we're going with the last question for this category. Again, another very popular question amongst the patient community. What is the relationship between EDS and Lyme?
The response is simple and complex at the same time, because there is not any direct relationship at the moment bridging together EDS and Lyme disease. Both conditions might present musculoskeletal pain, fatigue, connective tissue anomalies. Nevertheless, the monogenic variants of EDS are hereditary disorders, Mendelian disorders. Hypermobile EDS and HSD are chronic conditions with a tendency to familial clustering, but without a formal genetic background, while Lyme disease is an infection disease. However, given the partial symptomatological overlap, circumstances could exist in which a patient with a suspicion of EDS requests the exclusion of Lyme disease and vice versa. In addition, we cannot exclude that an individual is simultaneously affected by EDS and Lyme disease. This is also a possibility. Finally, as generalized joint hypermobility and additional unspecific physical signs reminiscent of a lax body are common in the general population, it is equally possible that an otherwise healthy individual with joint hypermobility develops Lyme disease, and the overlapping symptoms generate nosological confusion. Medicine still contemplates gray zones. In this case, we cannot have a simple clarification. Thank you.
Thank you. Thank you very much, Marco. So we will move on to the next category. Charissa, please. Charissa, you're muted.
The next category is lifestyle, and the first question we have is about nutrition. What are the supplements indicated in patients with HEDS? Vitamins, minerals, and glutamine are some examples.
Okay, thank you, Charissa. While there are a handful of papers discussing nutritional contribution to the improvement of symptoms in EDS and HSD, there is not any scientific study carried out to document with evidence the efficacy of any dietary integration in hypermobile EDS and HSD. Indirect evidence suggests that, for example, a regular intake of ascorbic acid might improve some minor symptoms such as easy breathing by improving the cross-linking between collagen fibers. In case of fatigue, as previously anticipated by the hypothesis of a link between EDS and the secondary mitochondrial dysfunctions, cycles of oral intake of coenzyme Q10 might improve the symptoms. However, as stated in the previous response, there is not any convincing substitute to therapeutic exercise in improving the quality of life of people with hypermobile EDS and HSD. Thank you, Charissa.
1 second, I'm getting to... Okay. The second question, also for lifestyle, is for about health conditions. What can the patient do on a daily basis to alleviate and or delay the symptoms of the disease?
It is not a simple question. Anyway, I will try to. Anyway, according to shared opinions, people with recurrent or chronic musculoskeletal symptoms concurring with generalized joint hypermobility often present a defect in proprioception and some tendency to muscle hypotonia. The triad of ligamentous laxity, defective proprioception, and hypotonia leads to multi-joint instability, altered posture, lack of movement precision, gait instability, and a tendency to falls and bumps. All these sub-features tend to improve thanks to body weight control and physical exercise aimed at improving posture, core stability, limb and peripheral proprioception, and subsequently the muscle tone, especially around the large and more unstable joints. Moderately and severely symptomatic people and those with events of joint macro instability deserve to approach the therapeutical exercise with a gentle and progressive way, and to be taken in charge by a physical therapist with experience in joint hypermobility. In people with symptomatic joint hypermobility, a treatment based on drugs, physical rest, and prolonged movement limitations alone is destined to worsen the symptoms sooner or later. There is not any efficacious alternative to physical therapy and therapeutical exercise for people for symptomatic joint hypermobility to date. A diagnosis of postural orthostatic tachycardia syndrome or any other forms of orthostatic intolerance indicates the introduction of the non-pharmacological resources for the prevention of the related symptoms. This is a summary, short summary that can be useful for maintaining an acceptable level of symptoms in people with symptomatic joint hypermobility. Thank you.
Okay, the next question is for diagnosis in pediatrics. How can we make sure that we are not failing in pediatric diagnosis of HEDS, or formerly known as type 3, as it is always claimed that children are very flexible?
I apologize in advance because in my response there is a small criticism to the question. According to the 2017 nosology, fixing a diagnosis of hypermobile EDS is difficult in children because many diagnostic criteria refer to acquired signs which may not be visible before puberty yet. However, if a child presents a Baton score equal or above 6 and joint pain compatible with the distribution of hypermobility, may be still diagnosed as HSD, hypermobility spectrum disorder. As stated into the nosology in 2017, while hypermobile EDS is an irreversible diagnostic state, this is not the case for hypermobility spectrum disorders. The latter are conditions featuring recurrent or long-lasting symptoms which might ameliorate significantly over time or thanks to treatments. Only a subgroup of people at the moment with hypermobility spectrum disorders become patients with a chronic disease in adulthood. Direct observations supports the existence of a subgroup of symptomatic children with generalized joint hypermobility, with or without additional physical signs suggestive of a lax body, but without a molecular diagnosis, who have lost symptoms and the positive Baton score after puberty. Hence, the difficulties in diagnosis hypermobile EDS in children denote the evolving, but also the quantic nature of the phenotype. Finally, children with generalized joint hypermobility without joint instability and musculoskeletal symptoms, but featuring one or more comorbidities, for example, a child with a Beto score of 8 out of 9 and POTS, but without musculoskeletal symptoms, in my opinion, do not receive any real medical advance in receiving a further diagnosis in addition to the comorbidities themselves. So they could be efficiently treated by thanks to the diagnosis of the comorbidities, observing the presence of generalized joint hypermobility without any other musculoskeletal manifestations could not be of any significant support to the treatment of the postural autophagy, the cardiovascular dysautonomia. Thanks.
Thank you, Marco. We have another question left. 1 second. Okay, this question is about research. What are the main lines of research on HEDS that are currently active?
According to the most recent publications and the data presented at the International Symposium on EDS and HSD in Toronto this year, the main topics of research in the field of hypermobile EDS include the clinical overlap between hypermobile EDS and hypermobility spectrum disorders, as well as their relationship with other apparently unrelated conditions, such as muscle activation syndrome, the natural history of hypermobile EDS and HSD, and the possibility of patients' stratification for prognostic and treatment applications, but also pediatric manifestation of hypermobile EDS and HSD for an early diagnosis of prognostication in the adult life. More in general, in the broader field of EDS, there are strong interests in developing alternative and more effective therapies for the reduction of the cardiovascular risk in vascular EDS. Thank you. I finished.
I'm not going to start the slides up right now because the next thing that we have are some questions from the audience. I will take a question from Maurizio. Go ahead.
Other countries. Are there countries where the EDS hypermobility form has been reported with higher frequency? And if yes, are the epigenetic...
I will read it out loud. Are there countries where the EDS hypermobility form has been reported with higher frequency? And if yes, are there epigenetic influences linked to nutrition, style of life, etc., that might be spread out the clinical symptoms?
Okay. For the first question, the epidemiology and therefore the frequency of hypermobile EDS and HSD is an hot issue because at the moment we don't have any consistent data defining the real epidemiology of the phenomenon in any countries, any European countries. But there are some indirect evidence that, especially collected in UK, that symptomatic joint hypermobility, so a combination that might correspond to hypermobility spectrum disorders at least a subgroup of people of hypermobile EDS might be has 1% in the general population. But there is still a debate on this point. Concerning the second question, it is reasonable that epigenetic factors might contribute to the genesis, so the development of joint hypermobility and consequently the related manifestations. But I don't have any data to share on this point, and I didn't find any interesting evidence in the literature yet on this. Thank you.
Okay, the next question is from Christine, and it is there a link between HEDS and osteoporosis?
I can remember at least 2 papers documenting a reduced bone mass in people with hypermobile EDS and perhaps hypermobility spectrum disorders. We don't have publications. We don't have publications by our group on this issue, but also in our experience, reduced bone mass is a common finding in people, at least in adults with hypermobile EDS and hypermobility spectrum disorders. At the same time, we didn't find a significant increase in fracture rate in these patients. In at least one publication, the authors reported an increased rate of fractures. So the question is still debated. At the moment, we usually propose DEX analysis in adults with hypermobile EDS and hypermobility spectrum disorders and recommend standard treatments in case of a reduction of the bone mass. Thank you.
Thank you very much, Marco. We still have a couple of questions more from the audience. The next question is from Celia, and she asks, I have EDS, initially hypermobile due to my symptoms, but my genetics show COL12A1 altered, and it's classified as a VUS. Is there any scientific evidence to support this? How can I differentiate between hypermobile and myopathic EDS? Can I have both?
It is an articulated question. Anyway, variants of an uncertain significance don't mean anything. If you find a variant of unknown significance in an apparently related gene, you didn't find a diagnosis. You didn't find a presumptive diagnosis. The variant should be changed to a likely pathogenic status by functional studies, segregation studies. In the absence of these elements, finding a variance of unknown significance in a report means a negative report. Collagen genes are very big genes. Finding variants of unknown significance is extremely common also in the general population. So finding a variant of unknown significance in collagen collagen 5A1 in a patient with a clinical diagnosis of hypermobile EDS supports the diagnosis of hypermobile EDS, first of all. Normally, a patient has a single diagnosis in the context of uncommon or rare diseases. While I cannot exclude the possibility in total, the possibility that a patient might have simultaneously 2 diagnoses, hypermobile EDS and myopathic EDS, I assume that this phenomenon is exceptional. So having myopathic EDS means that you have a clear genotype supporting the diagnosis of myopathic EDS. I think that this response might be clear for the patient, but can the patient reply if he or she understood what I said? No.
Thank you, Marco. Let's see if Celia is
okay.
Class and she can reply to your question. We will be delighted to explain a bit further if she hasn't understood.
Okay.
Thank you. So we have a last question from the audience. It's from Nuria, and she's asking regarding small fiber neuropathy. The question goes, we know that Ehlers-Danlos syndrome has no cure, but how can small fiber neuropathy could be treated, and how can it be diagnosed?
The diagnosis of small fiber neuropathy stands of a set of symptoms that should be in line with the hypothesis. Usually, neuropathic pain with specific distributions, burning sensations at the ends, limbs, or on the skull. And you should have excluded any other peripheral nerve diseases. And finally, the diagnosis of small fiber neuropathy is usually obtained by skin biopsy, a specific skin biopsy that should be carried out and examined by a laboratory with experience with small fiber neuropathy. Small fiber neuropathy is a complex disease because similarly to Ehlers-Danlos syndrome, doesn't have a definitive treatment, but there are drugs that can be used to modulate symptomatology. In many European countries, there is an increasing number of neurologists that are developing expertise in this field. So I suggest to the patient to, first of all, investigate instrumentally the diagnosis, and then ask to the general practitioner the possibility to get in touch with a neurologist with expertise in small fiber neuropathy.
Thank you very much, Marco. Celia has replied regarding your answer. And she's saying, yes, more or less, I understand you, Marco, but clinical supports both. Muscular hypotonia, collagen failing around all the body, 2 surgeries in my hips, shoulder issues, knee issues, ATM, temporomandibular joint issues, chronic pain generalized. She's a woman in her 36 years.
Okay. Just a final remark. The symptoms and features that the patients report are absolutely in line with both diagnoses. But while hypermobile EDS does not present additional, more specific feature, myopathic EDS have specific instrumental and molecular features. So, for example, a muscle MRI and molecular testing could easily help in differentiating between hypermobile EDS and myopathic EDS. Muscle MRI and genetic testing.
Okay, I think we have come at the end of our questions. I want to thank you, Marco, for answering all our questions, and thank you for ERN-ReConnect for providing this platform for this webinar. And thank you to all the people that have participated and sent us all these questions. We will leave you with, let me share the screen one more time, with a quote. 1 second. No other condition in the history of modern medicine has been neglected in such a way as Ehlers-Danlos syndrome. This has been by now retired Professor Rodney Graham, a rheumatologist. There's something to leave with you. And then again, thank you. Remind you to follow ReConnect, the ERN-ReConnect on social media, on Facebook. You can find us on YouTube, Instagram, and LinkedIn. You can subscribe to the newsletter. You can do that by sending an email to the ERN-ReConnect PISA team. or you can just scan that. For more information, you can scan the QR code. And again, thank you very much and a very nice evening. Thank you.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Bye.